Welcome to our video on vertigo. Let's begin. In this lecture, we will first introduce the terms of vertigo and dizziness. Then we will talk about central and peripheral types of vertigo. Before we start discussing each of these conditions, it's worth mentioning how the term dizziness is related to vertigo and presyncope. Vertigo and presyncope are the subtypes of dizziness. Vertigo is the sensation of spinning while being stationary. Presyncope, on the other hand, is the actual imbalance due to decreased cerebral perfusion. Now let's talk about the central vertigo. For central vertigo, we will discuss its definition, causes, clinical presentation, diagnosis, and management. Central vertigo is the sensation of spinning while being stationary due to central nervous system dysfunction. Let's talk about the causes of central vertigo. Vestibular migraine can induce central vertigo. Additionally, cerebellar and brainstem stroke can damage vestibular nuclei, inducing central vertigo. Multiple sclerosis causes central vertigo due to demyelination of the central nervous system. Finally, intracranial tumors can affect the vestibular nuclei or cerebellum, causing central vertigo. This is certainly not a comprehensive list of causes of central vertigo. However, these are conditions most commonly tested on USMLE Step 2 CK in the context of vertigo. Before we individually discuss the conditions that we mentioned on the previous slide, let's review the general features of the central vertigo. This information is super high yield in order to distinguish central from peripheral vertigo. Generally, any type of vertigo is commonly accompanied by nystagmus, that is, oscillatory eye movements. Central vertigo can have nystagmus with any direction, namely horizontal, vertical, torsional, or combination of any of these. Nystagmus has fast and slow phase. Slow phase is the initial slow deviation of the eyes, which is followed by the fast phase. The fast phase is the fast correction of the eye movement direction by cortical impulses. Actually, the name of the nystagmus is based on the direction of the fast phase. Nystagmus in central vertigo is non-fatigable, which means that it lasts more than 1 minute. Nystagmus is not inhibited by gaze fixation on the object either. Finally, nystagmus in central vertigo has no latency period. Latency period is the time between the provocative test and the onset of nystagmus. Absent latency period, in turn, means that nystagmus in central vertigo starts immediately during the provocative test. Central vertigo usually has no tinnitus or hearing loss. It is accompanied by central nervous system symptoms like diplopia, dysarthria, numbness, and weakness. Finally, postural instability is so severe that walking is usually not preserved. This is a patient with nystagmus. Please note the horizontal oscillatory movement of the patient's eye. Let's try a question. A 65-year-old man is brought to the emergency department due to severe headache that started 2 hours ago. His past medical history is significant for uncontrolled hypertension. The physical exam reveals left-sided dysmetria and dysdiadokinesia. The patient feels dizzy and he has oscillatory eye movements with the fast phase to the left. A non-contrast head CT scan reveals hypodense area in the left cerebellum. What are the likely characteristics of this patient's eye movements? This patient has headache, left-sided dysmetria, and dysdiadokinesia. A non-contrast head CT scan reveals hypodense area in the left cerebellum. All of these findings are consistent with an ischemic cerebellar stroke. He feels dizzy and has oscillatory eye movements with the fast phase to the left. This is the classic description of the vertigo with nystagmus. Since he has the cerebellar stroke, he likely has central vertigo. In case of central vertigo, the nystagmus is non-fatigable with no latency period. Additionally, it is not inhibited by gaze fixation, and it is not associated with hearing loss or tinnitus. Finally, the patients with central vertigo commonly have other CNS symptoms like dysmetria, dysdiadokinesia, dysarthria, and so on. Now let's discuss the clinical presentation of central vertigo in the context of different conditions. Vestibular migraine is characterized by vertigo with nystagmus. It's high yield to remember that vertigo is absent between the migraine episodes in patients with vestibular migraine. If the patient has vertigo even in between the episodes of migraine, then we should look to the other causes of vertigo. The patient also has the other classic features of migraine like unilateral pulsating headache and photophobia. Let's move on to the multiple sclerosis. Multiple sclerosis is a central nervous system demyelinating disorder. It can present with vertigo and nystagmus. Patients also have other classic features of multiple sclerosis like optic neuritis, spastic weakness, and neurogenic bladder. Let's move on to the cerebellar and brainstem stroke. Cerebellar stroke is characterized by sudden onset, persistent vertigo. It also presents with the cerebellar signs such as ataxia, dysmetria, and dysdiadochokinesia. Dysmetria is when the patient overshoots his or her finger while trying to touch the physician's finger. Dysdiadochokinesia, on the other hand, is inability to perform rapid alternating movements. Similarly, the brainstem stroke also causes sudden onset, persistent vertigo. It is also characterized by contralateral sensory or motor loss, depending on whether the lateral or medial part of the brainstem is infarcted. Ipsilateral cranial nerve deficit occurs due to damage to the cranial nerve nucleus. This is a patient with normal cerebellar function performing the rapid alternating movement of the right hand. In contrast, this is a patient with cerebellar stroke displaying dysdiadochokinesia. Please pay attention to his inability to rapidly perform the alternating hand movement. Finally, intracranial tumors can also cause central vertigo. It's worth mentioning that infratentorial tumors mostly result in vertigo and nystagmus. Example of such neoplasms is the cerebellar hemangioblastoma. The other symptoms of the intracranial tumor depend on the exact location. Seizures occur due to increased intracranial pressure. Sensory loss is due to compression of ascending sensory tracts. Motor weakness occurs due to compression of descending corticospinal tract. Dysarthria and dysphagia can also occur if the tumor compresses vagal nucleus in the medulla. Let's move on to the diagnosis of the central vertigo. Brain imaging is usually performed to identify underlying pathology. Imaging modality is chosen depending on suspected etiology. For example, if cerebellar or brainstem stroke is suspected, we can perform non-contrast head CT scan to exclude hemorrhage. On the other hand, MRI is the gold standard for diagnosing the multiple sclerosis. Caloric test is another diagnostic test used to document the vertigo and nystagmus. Installation of warm water in the ear canal causes ipsilateral nystagmus. In other words, slow phase of the nystagmus will be directed away from the instilled ear, while fast phase will be directed toward the instilled ear. In contrast, cold water installation of the ear canal causes contralateral nystagmus. This means that slow phase of the nystagmus will be directed toward the instilled ear, while fast phase will be directed away from the instilled ear. Three most important findings on caloric test used to differentiate peripheral from central vertigo include unilateral weakness, bilateral weakness, and the failure of fixation suppression. Unilateral and bilateral weakness represent the weakness of the induced eye movements by the test, and this is likely caused by peripheral vestibular diseases. In contrast, failure of nystagmus to be suppressed with fixation, the phenomenon also known as failure of fixation suppression, is likely caused by central cerebellar disease. Here is the warm caloric test. The direction of the slow phase is away from the ear instilled with warm water, while the direction of the fast phase is toward the ear. Here you see the cold water caloric test. Please pay attention to the fact that the direction of slow phase is toward the ear instilled with cold water, while the direction of the fast phase is away from the ear. Let's try a question. A 35-year-old woman comes to the physician due to sudden left-sided vision loss and painful left eye for the last 3 hours. She complains of urinary incontinence. She had weakness of her left hand 2 weeks ago and paresthesia on her right thigh 4 weeks ago, but these symptoms have completely resolved. The physical exam reveals vertical upbeat nystagmus. What is the best next step in the diagnosis of this patient? This young woman has sudden vision loss and painful left eye. This is likely consistent with optic neuritis. She had weakness of her left hand 2 weeks ago and paresthesia on her right thigh 4 weeks ago. This description is consistent with the symptoms disseminated in time and space. In other words, the patient experiences symptoms on different parts of her body during different times. She also complains of urinary incontinence. The physical exam reveals vertical upbeat nystagmus. All these findings suggest the diagnosis of multiple sclerosis. The best next step in the diagnosis of multiple sclerosis is MRI of the brain to look for the areas of demyelination. Management of central vertigo includes antiemetic agents, antihistamines, or antimuscarinics to prevent vertigo-associated nausea and vomiting. Otherwise, we should treat the underlying condition. For example, vestibular migraine can be treated with sumatriptan or dihydroergotamine. Multiple sclerosis needs multifactorial therapy. The therapy for multiple sclerosis include disease-modifying drugs like natalizumab and symptomatic medications like baclofen and intravenous steroids. The patient with stroke should be administered aspirin, clopidogrel, and TPA therapy specifically in case of ischemic stroke. Finally, intracranial tumor can be treated with surgery, chemoradiotherapy, or both. Let's move on to peripheral vertigo. We will discuss definition, pathophysiology, clinical presentation, diagnosis, and management of peripheral vertigo. Peripheral vertigo is the sensation of spinning while being stationary due to dysfunction of the inner ear or vestibulocochlear nerve. That is the eighth cranial nerve. Let's talk about the pathophysiology of peripheral vertigo. Inner ear or vestibulocochlear nerve dysfunction sends abnormal impulses to the vestibular system. This is how peripheral vertigo develops. Examples of conditions causing peripheral vertigo include benign paroxysmal positional vertigo, vestibular neuritis, acute labyrinthitis, Meniere's disease, and the acoustic neuroma. This is not the comprehensive list of the causes of peripheral vertigo, but these are the conditions most commonly tested on USMLE Step 2 CK exam. Before we move forward, let's briefly recall the inner ear anatomy. Inner ear includes cochlea, the structure responsible for hearing. Inner ear also includes the vestibular apparatus, that is, utricle, saccule, and 3 semicircular canals. These structures are responsible for maintaining the balance. Here we also see the vestibulocochlear nerve, which transmits all the signals from the inner ear to the vestibular system and the cerebral cortex. Dysfunction in any of these structures that we mentioned can lead to peripheral vertigo. Please note that although the vestibulocochlear nerve enters the cranium, it is part of the peripheral nervous system, just as the other cranial nerves. So vertigo due to cranial nerve 8 dysfunction is considered peripheral rather than central. Before we individually discuss the causes of peripheral vertigo, let's talk about its general features and compare it to central vertigo. Peripheral vertigo is mostly accompanied by horizontal nystagmus. In contrast to the nystagmus from central vertigo, the nystagmus from peripheral vertigo is never purely vertical or purely torsional. Another difference is that the nystagmus due to peripheral vertigo is fatigable. In other words, it lasts less than 1 minute. It is also inhibited by gaze fixation on the object. Let's recall that the nystagmus from central vertigo does not have latency period, while the nystagmus from peripheral vertigo does have the latency period up to 1 minute. Since the underlying etiology might affect the inner ear, peripheral vertigo can be accompanied by hearing loss and tinnitus. Finally, in contrast to the central vertigo, there are usually no other CNS symptoms, and walking is preserved. Benign positional paroxysmal vertigo is due to displaced otoliths in the semicircular canals. In this condition, vertigo is induced by rotational head movements, such as turning in bed, because head rotation stimulates otolith movement in the semicircular canals. Vertigo in benign positional paroxysmal vertigo can also be triggered by backward head tilt. Vertigo is characterized by brief episodes, usually lasting seconds to minutes, and it may be accompanied by nystagmus. It's worth mentioning that benign positional paroxysmal vertigo has no auditory symptoms like tinnitus or hearing loss. A 27-year-old woman comes to the physician due to episodes of dizziness for the last 6 months. During the episode, she feels like the room is spinning around her. The episodes last seconds to minutes, and she experiences the symptoms when she turns from side to side in bed. Looking up also triggers her episodes. Caloric test induces oscillatory eye movements. What are the likely characteristics of this patient's eye movements? This patient presents with brief episodes of vertigo. The episodes last seconds to minutes, and she experiences symptoms when she turns from side to side in bed. Looking up also triggers her episodes. This is the classic description of benign paroxysmal positional vertigo, that is BPPV. Caloric test induces oscillatory eye movements or nystagmus. BPPV is the cause of peripheral vertigo. In case of peripheral vertigo, nystagmus is mostly horizontal, but never purely vertical or purely torsional. Additionally, it's fatigable, and it is inhibited by gaze fixation. Nystagmus, in the context of peripheral vertigo, has the latency period and is associated with hearing loss or tinnitus. Finally, the other CNS symptoms are usually absent. Let's talk about vestibular neuritis and labyrinthitis. As the name implies, vestibular neuritis is the inflammation of the vestibular part of the cranial nerve 8. Vestibular neuritis is associated with current or previous viral infection. It usually causes episodes of vertigo that can last for days. Importantly, vestibular neuritis has no hearing loss. As for the labyrinthitis, it is the inflammation of the inner ear structures, including that of cochlea. Labyrinthitis presents almost identically to vestibular neuritis. However, since labyrinthitis also damages the cochlea, it is accompanied by sensorineural hearing loss in contrast to vestibular neuritis. Let's move on to Meniere's disease. Meniere's disease is caused by endolymphatic hydrops, that is, accumulation of endolymph in the inner ear. It is characterized by a triad of vertigo, tinnitus or ringing in the ears, and sensorineural hearing loss. Acoustic neuroma, also known as vestibular schwannoma, is the Schwann cell tumor arising from the cranial nerve 8. Acoustic neuroma is a mostly unilateral tumor in the cerebellopontine angle. Importantly, bilateral vestibular schwannomas are associated with neurofibromatosis type 2. Acoustic neuroma can cause vertigo and sensorineural hearing loss due to involvement of the vestibular and cochlear segments of the cranial nerve 8, respectively. Acoustic neuroma can compress the adjacent structures, causing various symptoms. If it compresses the cranial nerve 7, then the patient can present with Bell's palsy. If vestibular schwannoma compresses the cranial nerve 5, then facial sensation will be decreased. And finally, if it compresses cerebellum, patient will present with ataxia and other cerebellar signs. This is a brain MRI showing acoustic neuroma. Please pay attention to the homogeneous mass at the right cerebellopontine angle. Here you have a patient with Bell's palsy, that is, facial paralysis. Please note his facial droop. As we already mentioned, Bell's palsy can occur in the setting of acoustic neuroma if the tumor compresses the cranial nerve 7. We will talk about diagnosis now. Benign paroxysmal positional vertigo can be diagnosed by the Dix-Hallpike maneuver. This maneuver uses sequential head and body movements in order to induce otolith displacement within the semicircular canals. For all the other causes of peripheral vertigo, audiometry should be performed to screen for concomitant hearing loss. MRI of the brain can reveal acoustic neuroma. Finally, the head thrust test is commonly positive in vestibular neuritis and labyrinthitis. Let's discuss it on the next slide. Here is the illustration of Dix-Hallpike maneuver. First, we rotate the head to 45 degrees on one side. Then we quickly lie the patient down and overhang the patient's head over the edge of the bed. We observe the presence of nystagmus in this position. Then we repeat the same maneuver on the other side. Here we see the illustration of the normal vestibulo-ocular reflex. First, we should ask the patient to fixate on the distant object. If we rapidly rotate the head in a healthy person, the eyes will stay fixated on the object. However, in the patient with vestibular neuritis or acute labyrinthitis, the eyes will first move in the direction of the head rotation, and then they will suddenly move back to the object. General management of peripheral vertigo includes antiemetic agents, antihistamines, or antimuscarinics to prevent vomiting. We have the cause-specific management for several conditions. First, benign paroxysmal positional vertigo is treated with Epley maneuver. This is the sequential head and body movements which bring the displaced otoliths back to their normal location. Patients with the vestibular neuritis can be prescribed acyclovir if herpes simplex virus is suspected to cause this disease. We can consider oral corticosteroids for labyrinthitis. Meniere disease is treated with low-salt diet and diuretics to decrease endolymph production. Finally, acoustic neuroma is surgically excised. Here we have a table summarizing the differences between the central and peripheral vertigo. Pause the video and take a moment to consider this table. And here we have the causes of central and peripheral vertigo that have been discussed in this lecture. Please pay attention to their key features so that you can recognize them in the question stems. So let's try a question. A 40-year-old man comes to the physician due to left-sided hearing loss. He also hears ringing sound in his left ear, and he has episodes when he feels like the room is spinning around him. The patient vomits during these episodes. His wife has noticed oscillatory movements of his eyes whenever he feels dizzy. Audiometry confirms the sensorineural hearing loss. In addition to antiemetic medications, which two interventions will likely benefit this patient? This patient has sensorineural hearing loss, tinnitus, and vertigo, accompanied by nystagmus. This triad is consistent with the diagnosis of Meniere disease. Meniere disease is caused by endolymphatic hydrops, that is, accumulation of excess endolymph within the scala media of the labyrinth. In addition to antiemetic medications, patients with Meniere disease typically benefit from low-salt diet and diuretics, which decrease the endolymph production. And that concludes the section.